algorithm, topical therapy is our primary mode of treatment. We will start with topical retinoids such as tretinoin. It is our initial management for most of the patient. It is beneficial for both comedonal and inflammatory papules and pustules. Okay, so the first step is to assess if there is any complication that warn us toward a more aggressive treatment, such as acne scarring, disfiguring, post-inflammatory hyperpigmentation or erythema, and significant psychological distress. So if it's present, we would manage as moderate to severe acne vulgaris. If it's absent, then we would assess the lesion type. Is it comedonal or pustular plus or minus comedonal lesion? So if it's only comedonal, then we would treat with topical retinoids. If it's papulopustular with or without comedones, we would give topical retinoids and benzoyl peroxide. We would instruct the patient to apply topical retinoids once daily at night. We may start it slowly to minimize the risk of skin irritation. It could be applied every other night or every other third night, with the goal of progressive increasing till it become daily use. So we'd inform the patient that they should use it on a dry skin and they should apply a small amount, a pea-sized amount, to the entire face rather than just spot treatment. Okay, so if the response is satisfactory, then we will continue topical retinoid as maintenance therapy. If it's unsatisfactory, we would consider either increasing the concentration or change it to another alternative. If it's satisfactory, then we would continue. Unsatisfactory, then we would manage as moderate to severe acne vulgaris. If the patient have papulopustular acne and they have to use benzoyl peroxide with topical retinoid, we have to inform them that they shouldn't be used at the same time. So benzoyl peroxide should be applied on the morning and retinoid in the evening. Also, topical retinoids are not recommended in pregnancy. For benzoyl peroxide, it is a topical agent with both antibacterial and comedolytic property. We would use lower concentration as higher concentration may have more likely to cause skin irritation and there is no increased benefit. And the patient should be advised that direct contact with benzoyl peroxide could cause bleaching of the fabric or the hair. So as I said before, it is used for papulopustular or plus or minus comedonal acne. We would give topical retinoid and benzoyl peroxide. So if the response was satisfactory, then we would follow a stable improvement for at least 3 to 6 months with transition to retinoid monotherapy as a maintenance therapy. But if the response was unsatisfactory, then we would consider adding topical clindamycin, which is antibiotic. So topical clindamycin is applied once or twice daily with benzoyl peroxide. The benefit from it is to decrease the development of antibacterial resistance and improves the treatment efficacy. So for alternative agents such as salicylic acid, which is comedolytic agent that is useful for patients who cannot tolerate topical retinoids or they cannot obtain it. For azelaic acid, it is both antibacterial, comedolytic, and anti-inflammatory property. So it could improve acne-induced post-inflammatory hyperpigmentation, and it's applied twice daily. For topical erythromycin, it is alternative to clindamycin. However, it has higher rate of Cyanobacterium acne resistance, and it could be used with benzoyl peroxide to minimize the risk of resistance, and it applied once or twice daily. So in summary, in patients with mild comedonal acne, we would give topical retinoids. Alternatively, we would use azelaic acid or salicylic acid. For mild papulopustular and mixed comedonal and papulopustular acne, we would give topical retinoids and topical antimicrobials or benzoyl peroxide and antibiotic. So in general, we would assess the response of the treatment after 12 weeks. For resistance disease or failure of response to the first-line topical treatment, we have to consider if the patient are poorly adherent to the treatment regimen, if there is incorrect diagnosis, or there is any underlying disease like endocrine disorder. We discuss moderate to severe acne vulgaris. So the management here involves consideration of systemic therapy such as hormonal agent, antibiotic, and oral isotretinoin. So for the algorithm, we will start by assessing the following. Is there is any extensive nodular acne, prominent scar, significant acne-related psychological distress. This indicates severe acne. If they are present, then we would discuss the initial use of oral isotretinoin, and we will ask ourselves, it is papulopustular lesion or nodular? If yes, then the treatment option includes these, such as oral tetracycline, combined estrogen, progesterone, oral contraceptives only for females, oral spironolactone, also only for females, and oral isotretinoin. If it's only comedonal, there is no papulopustular or nodular lesion, we'd give combined estrogen, progesterone, oral contraceptives also for females, and oral spironolactones for females only as well, or oral isotretinoin. Then we would assess the response at 3 months in both of them. If there is no response, then we would switch agent or escalate the oral isotretinoin. Also for this, we would combine these agent and escalate oral isotretinoin. So the mechanism of action for isotretinoin, that it's involved only medication that address all of the 4 factors involved in the acne development. It will inhibit the sebum production, inhibit the bacterial proliferation and follicular hyperkeratinization, and it has anti-inflammatory properties. When it is appropriately used, it is used for severe reluctant nodular acne, such as in this algorithm, or it could be used in less severe acne. However, it is resistant, or the first-line treatment are failed, or if it's associated with scarring. Then we have to do baseline clinical and laboratory evaluation. We would ask for prior contraception failure, history of uncontrolled depression or suicidal ideation, hyperlipidemia, or family history of early onset hyperlipidemia, personal or family history of IBD, any eye problems such as dry eye or contact lenses use, heavy alcohol consumption, and extreme physical activity. So our aim to achieve a cumulative dose of 120 to 150 milligram per kg to decrease the risk of acne recurrence, and it's mainly achieved within 20 to 24 weeks. So we will start with 0.5 milligram per kg per day for the first month. Then we would increase it to 1 milligram per kg per day to minimize the risk of severe acne flare-up. For patients with severe inflammatory or nodular variant like acne convolvulata or acne fulminans, we will start with a lower dose to decrease the risk of flare-up. Also, we would give systemic glucocorticoids for first 2 to 4 weeks. Isotretinoin should not be given with tetracycline as it increases the risk of idiopathic intracranial hypertension or pseudotumor cerebri. And thank you for your listening. Moving on for special population. So patients with phototypes or Fitzpatrick of 4 till 7, they are highly prone to develop post-inflammatory hyperpigmentation, which comes from both acne itself and the irritation caused by the treatment. For younger children under the age of 7, it is abnormal for them to have acne, so we have to do workup for hyperandrogenism. For pre-adolescents aged between 7 till 12, we have to avoid oral tetracycline till the age of 8 because it causes tooth staining. Also, we have to avoid oral contraceptive until 1 year after the onset of menstruation. For pregnancy, remember that oral isotretinoin is contraindicated because it's highly teratogenic. Topical tazocine and other topical retinoids, also topical minocycline or tetracycline, are contraindicated in pregnancy. For associated diseases, if the patient shows sign of hyperandrogenism like hirsutism or irregular menses, so we have to investigate. Our acne treatment will repeatedly fail if we don't treat the underlying systemic cause first.
Acne complication. The most significant complication of acne is the psychological effect. Acne can cause embarrassment, anxiety, and may reduce the self-esteem due to the visible lesion, scarring, or hyperpigmentation. All of these can negatively affect the social life and employment of affected individuals. Another complication, especially for the long-term acne treatment, is the gram-negative folliculitis. This condition typically develops in a patient who have been on systematic antibiotic for a long time, especially tetracycline. At first, their acne will improve, but later suddenly will worse and becomes resistant to the antibiotic therapy. Clinically, these patients present with inflammatory pustule and nodules. When cultures are taken from the lesion, gram-negative organisms are found, such as enterobacteria, Klebsiella, Pseudomonas, Proteus, and E. coli. Most affected patients were male, 39 out of 46, indicating a possible risk factor. Acne fulminans is a rare but severe form of acne, marked by an acute eruption of a large, painful, inflammatory nodules and friable plugs, with resonance and ulcers and hemorrhagic crustes. These lesions may bleed and can form cysts. These conditions primarily affected the adolescent male with a pre-existing acne vulgaris. Can be triggered by isotretinoin therapy or may occur spontaneously. The pathogenesis is still unclear. The lesion usually involves the trunk. Acne filament may occur in association with the symptomatic symptoms like fever, malaise, bone pain, and arthralgia. There are 4 types of acne filaments. 2 occur spontaneously, and the 2 are induced by the isotretinoin. Each can appear with or without systematic symptoms. The most common type is the isotretinoin-induced acne filaments but without systematic symptoms.